Okay, so the last muscular dystrophy we'll talk about is FSH, facioscapulohumeral dystrophy. To really list the muscles that are involved, we really should call it facioscapulohumeral peroneal dystrophy, because the weakness tends to be face, scapular muscles, humeral muscles, and often with foot drop along with it. Okay, so this is less common, about 1 in 100,000 cases. Patients generally present with symptoms in the end of the first or second decade, sometimes middle age, and generally it presents with facial weakness. That's often the earliest thing that is noticed. So for example, patient could always whistle. Now they can't whistle for some reason. Or a patient could always suck liquids with a straw. Now all of a sudden they can't. Okay, so facial weakness is bothersome and noticeable as one of the early symptoms, and you'll notice that on examination. Weakness of the shoulder girdle, however, is more likely why the patient's going to ask to see a doctor. Okay, and frequently these patients will have scapular winging. Interestingly, the deltoid muscle is frequently preserved, which often leads to a high riding scapula, as you can see in the picture here. Okay, so they have scapular winging, weakness of the biceps muscle, and frequently weakness with foot dorsiflexion. So they'll present with a foot drop in addition. Okay, so this is a slowly progressive condition. Life expectancy is generally not reduced. Maybe 20% of patients or so with FSH dystrophy require a wheelchair. And just like everything here in neurology, the explosion of genetics information has been very helpful. So this condition is autosomal dominant, and we can find the genetic abnormality in most patients, chromosome number 4. And there's a commercially available genetics test for this. How do you treat FSH dystrophy? Again, we're going with symptomatic treatment. There is no cure. So we can treat a foot drop with an AFO, just like we would do with myotonic dystrophy. Occasionally, we can refer the patient to orthopedics for a fixation of the scapula if there's a real problem with scapular winging. All right, so there are some things like this that can be done to help patients, but no cure. Okay, let's move on to our second category now of muscle disease, and that is inflammatory myopathy. Okay, and we want to contrast between polymyositis, dermatomyositis, and inclusion body myositis. And you can see the incidence there, that dermatomyositis is less common than poly and inclusion body myositis. Perhaps one thing just to note here on this table is how common inclusion body myositis is. Inclusion body myositis, there used to be a category known as a steroid-resistant polymyositis. Well, it turns out most of those patients actually had inclusion body myositis. Okay, so you want to be familiar with that condition, as we'll talk about. Let's talk about dermatomyositis first of all. Dermatomyositis, these are autoimmune diseases, but there's a different pathophysiology between dermatomyositis and polymyositis. Dermatomyositis, it appears that the site of attack is at the microvasculature level in the muscle. And this is sometimes referred to as a complement-mediated vasculopathy, okay, as opposed to polymyositis, where the attack is directly against the muscle fibers. Okay, so that's what goes on in the muscle. But of course, dermatomyositis has the skin manifestation, which is so typical and usually what makes the diagnosis relatively easy. So the classic dermatologic findings are an erythematous scaly lesion over the cheek or the malar region, often the eyelids, where we get a violet color around the eyes or of the eyelid. And this is known as a heliotropic rash, and heliotropic means toward the sun. So the sun-exposed areas, such as the back of the neck, for example, are more often involved in dermatomyositis. Okay, so some pictures here just showing you different patients that have dermatomyositis with a typical skin lesion. In the extremities, the scaly erythematous lesions tends to be over the extensors, so over the knuckles and the wrist, for example, or over the dorsal surface of the elbows would be another common area, extensor surfaces. Sometimes the involvement around the eye can be severe and can cause edema that's known as periorbital edema, So you may notice some swelling around the eyes. Dermatomyositis often also has some other unique features. One of them is known as cutaneous calcinosis. Okay, and you can see on the pictures here these subcutaneous depositions of calcium under the skin, and you can see it on the X-ray there as well. Okay, so patients with dermatomyositis generally present with subacute progressive proximal weakness. What does subacute mean? Well, generally that is weakness that presents over weeks to months. So the patient is in to see their doctor about this problem within weeks or sometimes months from the onset. Okay, and because this is a muscle disease, again, not affecting the upper or the lower motor neurons, sensations entirely normal. Reflexes typically are preserved unless there's just a lot of atrophy of muscles. Okay, so the patient comes in with proximal muscle weakness. And again, maybe in the arms, what would be a symptom of that? Well, you can't, for example, put dishes up on the cupboard very well if you have proximal muscle weakness. Or in the legs, walking upstairs, getting in and out of a deep sofa or out of a car will be difficult if you have proximal muscle weakness. Esophagus, of course, contains skeletal muscle, and so some patients, maybe 1 in 3, will have some degree of dysphagia. Okay, but fortunately, respiratory involvement is uncommon. Now, boards will often give you a case of dermato or polymyositis, and they'll include myalgias, muscle pain. Okay, but recognize in the real world that probably no more than 25% of patients with either of these conditions have myalgias. So generally it's painless. One exception would be kids that have dermatomyositis are probably more likely to have myalgias. Okay, patients with dermatomyositis may have joint contractures, and interestingly there's some increased risk of cancer in dermatomyositis, although not high. Okay, so you're seeing a patient with progressive proximal weakness. They have the skin lesions. How do you make a diagnosis? Well, again, as you might predict, this is an active muscle breakdown. Patient was going from normal to now having pretty significant weakness over a few weeks or months, so the creatine kinase level will be significantly elevated in dermatomyositis. Okay, the other thing that you would do is an EMG. Okay, EMG will be a subsequent lecture, but let's just say for now it reveals myopathic findings, and we'll define what myopathic is later. But EMG can be very helpful in terms of just confirming, yes, this is a muscle disease, and yes, this is an active breakdown muscle disease. Okay, but muscle biopsy is where we nail down the diagnosis in dermatomyositis. And I'll show you some pictures here. The classic pathognomonic finding of dermatomyositis is what's known as perifascicular atrophy. And just look at the muscle slide here. You can see that the atrophy is out around the periphery of the fascicle. Okay, a very unique classic feature for dermatomyositis. Okay, so once you've confirmed diagnosis by muscle biopsy, and typically we'd biopsy an involved muscle like the quadriceps muscle, once you've nailed that down, then you want to begin treatment. And generally, steroids are the medication of choice initially for dermatomyositis. Steroids are generally very effective. Other immunosuppressants, and if you have a really progressive case, IVIG or plasmapheresis can be used to boost patients along that have dermatomyositis. Okay, I'm going to say a little more about steroids and immunosuppressants when we talk about treatment of polymyositis, because the treatment for these conditions is very similar. Okay, again, so if I could just list some unique features that distinguish dermatomyositis from polymyositis, would be, of course, the skin rash. Dermatomyositis can affect children. Polymyositis affects adults. The joint contractures and the subcutaneous calcinosis is unique for dermatomyositis. The muscle biopsy finding is specific for dermatomyositis, not polymyositis. That's known as perifascicular atrophy. And again, the pathophysiology is different. Dermatomyositis, it's a complement-mediated vasculopathy. Polymyositis, as we'll see, is quite different. Okay, so dermatomyositis has unique specific features. We lack those in polymyositis. All right, so polymyositis, the pathophysiology here is thought to be T cells that go out and attack individual muscle fibers. Okay, but the presentation in terms of the weakness is virtually indistinguishable from dermatomyositis. Subacute, progressive, proximal muscle weakness. Okay, again, a third of patients may have dysphagia, just like dermatomyositis. Respiratory involvement, not common. Myalgias, again, not common. Okay, and polymyositis may have an associated interstitial lung disease, but that can be seen in dermatomyositis, so it's not a distinguishing feature. Okay, so you're having this patient present with proximal muscle weakness. You think it's a muscle disease. Okay, so the diagnosis, again, the thought process will be quite similar. So you want to do a CK. It's going to be very elevated in polymyositis. You'll do an EMG, which will tell you it's a muscle disease, but EMG can't tell you specifically which one. It just tells you this is a muscle disease. And then you'll do a muscle biopsy. Now, in the muscle biopsy, the big picture here is just to know it's not specific like dermatomyositis. So you can say, yeah, it's an active breakdown muscle disease, but the pathologist can't tell you it's polymyositis versus other conditions. So the muscle biopsy is mainly helpful to rule out other types of muscle disease, not specific. Okay, but once you've done that and your EMG, your muscle biopsy confirm, yep, it's an active breakdown muscle disease, we've ruled out other conditions, then our presumptive diagnosis is polymyositis. Okay, so let's come back here to, because our treatment, again, is virtually the same for poly and dermatomyositis, let's say a little bit more about steroids. Because of the notable side effects of steroids, we're of course pleased to start patient on high-dose steroids and see good clinical improvement, which is generally quite obvious within, certainly by 3 months, typically sooner. But our goal is to taper the patient down to an every other day dose of steroids because side effects are so much reduced. So a general rule for that would be, let's say you have a patient on 60 milligrams a day of prednisone. And you've had good clinical improvement. Patient's strength is improved. They're doing much better on prednisone. Okay, typically we would drop 10 milligrams on alternate days about every week. Okay, so you'd have a patient take, maybe on odd days, they would drop 10 milligrams. So they'd take 60-50, 60-50. You do that for a week, and then 60-40, 60-40 for a week, 60-30 for a week. And you gradually come down. Okay, and then you would slow down the taper over time, okay, to try to eventually get the patient down to 20 milligrams every other day, if you can. Now, from 20 milligrams every other day, our taper is much slower, and so typically we'll drop just maybe only 2.5 milligrams every 2 weeks. Okay, so you're going to try to get down to as low a dose of prednisone as you can. Now, if a patient has more severe weakness, we'll need to consider other medications. But before we leave prednisone, let's just be aware of some things you need to do in a patient that you have on prednisone. First of all, we usually get a chest x-ray initially because we'd certainly like to know if a patient maybe has tuberculosis, they may need INH or some therapy for that. You'd like to know that before putting them on an immunosuppressant medication. We need to monitor some things in a patient that's on prednisone, so we'll usually do a DEXA, a bone scan about every 6 months, and if their bone density score falls below a certain standard deviation below the mean, they have osteoporosis, then obviously we want to begin treating with calcium, vitamin D, Fosamax if there's bone loss. Okay, you need to be very aware of these complications of steroids. Okay, so other medications, again, immunosuppressants. You've got a bad case of polymyositis. You need something else to help boost the patient along. We'll use immunosuppressants, typically azathioprine or Imuran is the most common one used, although methotrexate would be another consideration. And there's some pretty good clinical evidence now that these medications help. In one study, 64% of patients with both poly and dermatomyositis had some significant clinical improvement with Imuran. One thing to be aware of with Imuran, about 12% of patients have a very severe systemic reaction to Imuran, and typically with fever, abdominal pain, nausea, vomiting. The patient will tell you they have the flu, okay, but it usually begins in the first few weeks after you've started someone on Imuran. And if they have that kind of a reaction, you need to just stop the medication. The patient's not going to be able to tolerate it. Okay, so that's one side effect of Imuran or azathioprine. The other would be bone marrow suppression. Okay, and so we need to monitor a CBC carefully in patients on azathioprine. Typically, if they're going to have this, it develops within a few weeks or sometimes even out to 2 years after initiation with therapy. So we need to, the point is we need to do ongoing monitoring with a CBC. Now, let's say you have a patient with polymyositis or dermatomyositis who's not doing well. They're progressing. They're not responding to steroids. This is when we consider IVIG or plasmapheresis. And these are good options. They're both effective, very expensive, of course. But some patients we will give IVIG, for example, every 8 weeks as maintenance therapy. They just respond better to that than prednisone. More likely, you're just going to use this for your patient to give them a boost if they need it. Maybe you're seeing someone on first visit and they're not even ambulatory because it's progressed so rapidly. In that patient, you might want to just give them a course of IVIG to give them a boost early on. Okay, so our third condition here is inclusion body myositis. And the pathophysiology of this condition, it's similar to polymyositis, seems to be T cells activated against the individual muscle fibers. Some unique features, there is maybe 10% where this is hereditary, so there's a genetic component that seems more prominent in inclusion body myositis. Okay, but it has very unique clinical features. You should think of inclusion body myositis in an older man that's presenting with progressive weakness. So all of these patients, for the most part, are over the age of 50, much more common in men. And the distribution of weakness, think of 2 muscles in inclusion body myositis. In the legs, it's the quadriceps. So if your quadriceps are weak, your knees are going to buckle. And when you walk, you're going to fall. Okay, so falling would certainly be a complaint. But the other, and actually the most unique thing for inclusion body myositis is finger flexion weakness. Okay, what would you complain of if you have finger flexion weakness? Well, opening jars. Anything where your hand grip is going to be important. Okay, and so you'd want to look for that on examination. So you're seeing the patient, you're examining strength, and you find that finger extensors are normal. Okay, you turn the hand over, ask the patient to squeeze your hand tightly, you check the finger flexors, and you find significant weakness. Okay, that would be classic for inclusion body myositis, finger flexion weakness. Okay, myalgia is not common, inclusion body myositis. Around 40% of patients may have dysphagia, okay, just like with poly and dermatomyositis. And interestingly, these patients frequently have a mild, often subclinical polyneuropathy. That's something we might pick up more on EMG than you would clinically. Okay, so we have an older man coming in with progressive weakness. You're finding finger flexion weakness. The process for this, like the other muscle disease we talked about, CK, okay, which is usually elevated but not dramatic because IBM is a little more slowly progressive than poly and dermatomyositis. You would do an EMG, which would tell you it's a muscle disease, and you may find a muscle disease with some polyneuropathy on EMG. Those two together might suggest inclusion body myositis. And then a muscle biopsy. And here you can see some pictures of a muscle biopsy in inclusion body myositis. And so what we find are rimmed vacuoles and these inclusion bodies seen by electron microscopy. And these inclusion bodies are 15 to 18 or 15 to 21 nanometer cytoplasmic intranuclear tubulofilamentous inclusions. Okay, so you look for this on electron microscopy, which you can see here, and we have just these classic inclusion bodies, which nails down the diagnosis. So again, of the 3 inflammatory myopathies we've talked about, dermatomyositis, inclusion body myositis have unique, specific muscle biopsy findings. Remember, polymyositis does not. Now, unfortunately, we really don't have good treatments for inclusion body myositis. Unlike poly and dermatomyositis, prednisone doesn't look like it's helpful. IVIG does not look like it's helpful. Okay, so we really don't have a meaningful intervention. Now, very briefly, 2 more muscle diseases I'd like to make you aware of, and then we'll conclude this lecture. One of them is statin myopathy. Since these cholesterol-lowering medications are so commonly prescribed, we see a number of patients that have this statin-induced myopathy. And the family of medications that cause this are the HMG-CoA reductase inhibitors. And the incidence of this varies in reports, but somewhere between 2 and 7% of patients on statin medication develop this myopathy, most commonly myalgias. Okay, so patients come in with muscle pain. Less common, maybe no more than 1%, patients may actually have weakness as a part of this. Okay, so think about this in your patient. You put on the cholesterol-lowering medication. They come in with aches and pains, myalgias. Okay, very likely the medication. Very, very rarely, patients have been reported to have severe rhabdomyolysis, but that's very uncommon. And frequently, patients will even have completely subclinical myopathy. We'll find an elevated creatine kinase, but the patient doesn't have any symptoms. So stop the medication, and things generally clear up. All right, last condition that I'd like to make you aware of in the muscle disease category is something known as a critical illness myopathy. Okay, we're seeing more and more of these patients, and the story is generally the same. This is a sick patient that comes into the ICU generally for attack of asthma, perhaps status asthmaticus, a severe case. And the 2 medications that are implicated in critical illness myopathy are high-dose steroids, which of course are given for this condition, and neuromuscular blocking agents. Okay, so we look for those 2 medications related to critical illness myopathy. Often these patients are septic, they have multi-organ failure, but they're weak, and this is a myopathy. Okay, often these patients are on ventilator, typically they are, and when you examine them, they have severe diffuse weakness. Okay, it tends to be more in proximal muscles, so it follows our usual rule of thumb for a myopathy. Over time, these patients have atrophy and typically sparing of cranial nerves, okay, or cranial nerve musculature. So the weakness is in the arms and legs. And the CK, someone started on, let's say, a high-dose steroids for an asthma exacerbation. The CK may be normal, perhaps, for about 9 days or so, and then we may find the CK elevation. Okay, so our diagnosis in that case is critical illness myopathy, and over time and coming off of these medications, patients can have a good recovery. All right, so that's a quick run-through of muscle disease. Okay, and from here we're going to go on to our next category up the neuro axis and talk about neuromuscular junction disorders.